Balsillie Scholar Program brings scholars and industry professionals from around the world to research that intersectional area between governance and technology that we at the Balsillie School are so concerned about. So this talk is entitled Digital Epidemiology in Action, Harnessing Simulation Models for Evidence-Based Infectious Disease Control. And this is our third Balsillie Scholar research episode in the series that we're hosting. And, you know, it's something that is still very much on our minds, right? Since like COVID is not so far behind us that we don't still, well, I still think about it weekly, exactly, which we're about to hear all about. You know, let me just tell you a little bit about Dimitro. He's an associate professor at the Department of Mathematical Modeling and Artificial Intelligence of the National Aerospace University, Kharkiv Aviation Institute in Ukraine. He obtained his PhD degree in systems and means of artificial intelligence at the Kharkiv National University of Radio Electronics and continued his research as a postdoctoral research fellow at the Ubiquitous Health Technologies Lab of the University of Waterloo. His research focuses on simulating the spread of infectious diseases and applying AI tools and methods for public health and strategic communication. So delighted to have you, Dimitro, and the floor is yours.
Thank you, Anne, and thank you for Balsillie School of International Affairs for the opportunity to continue my research. So today we'll talk about actually the epidemic process. What is it? Why we need to simulate epidemics? How simple models works? Why actually classic models are not the best option to simulate the infectious disease spreading and epidemics. What is the role of AI in that domain? And we'll look at some applied tasks which solved or which are in the process of solving by me and my research team. But before we start, I want to read you one short piece from one book. So, in search of the birthplace of new pathogens, I set out on a cool rainy day to find a wet market in Guangzhou, the capital of the southern Chinese province of Guangdong. Wet markets are open-air street markets where vendors sell live animals captured from the wild to consumers to slaughter and consume. They serve with a Chinese taste for what's called a way of wild cuisine, in which exotic animals from snakes and turtles to bats are prepared into special dishes. It was in a wet market in Guangzhou that the virus that nearly caused a pandemic was born. This particular virus normally lived inside horseshoe bats. It was a kind of coronavirus, family of viruses that mostly cause mild respiratory illness. But the virus that was hatched at the wet market in Guangzhou was different. So it looks like the beginning of COVID pandemic, yeah? But actually this book by Sonia Shah was written in 2016, like 3 years before the COVID-19 pandemic. And it's not magic, it's science. And that means that we can actually predict, we can forecast the pandemics and epidemics based on the laws of epidemiology, of statistics, and on other sciences. So what actually the epidemic process is? Epidemic process is a set of cases of an infectious disease occur one after another, and the continuity and regularity of which is supported by the presence of a source of infection, transmission factors, and the susceptibility of the population. This biological basis is the interaction of three constituent links, the source of infection, transmission mechanism, and the susceptible organisms. Among the features of the epidemic process, we can single out vertical transmission, that is infection from father to offspring, vector transmission, that is infection through a third object like tools or insects, population heterogeneity, age groups of the population, varying infectivity as a result of seasonality or other influencing factors, heterogeneity of the environment, immunity formed by both natural and artificial factors, the cyclicity and cyclical nature of the epidemic process, irregular ups and downs, and morbidity arising from episodic changes in social natural factors, and seasonal and off-season frequency. So why do we need to model epidemic processes? Actually, we luckily cannot do experiments with live people, so we can simulate our society and simulate the spreading of infectious diseases in that simulated society. And such models can represent unique approaches to integrate epidemiological knowledge in such experiments. And they also allow to link epidemiology with other sciences like social, behavioral sciences, ecology, resource management, and so on. So let's move from the general words and theory to practice and look at real models of epidemic processes. I believe that all of you have heard about SEIR model during the COVID-19 pandemic. So let's find out how does it works. And before we start, we need to understand what we want to describe. Then build the model and use real data in the abstract model. And actually, what are the variables in the model? So in the simple SEIR model, we have the population divided by 3 states. The first one is susceptible individuals, the second one infected individuals, and the third one state R, which is recovered, or in some models recovered plus death removed from the models. All that variables have links. In real life, quantities change over time. That is dynamic. Therefore, it's necessary to describe natural processes dynamically. So we have transition from one state to another. Let's look at mathematics behind that. I hope it wouldn't be so complex. But anyway, we can describe that model with a system of differential equations. And the first variable is delta S, which is the change of the quantity of susceptible individuals. So the more people are infected, the faster they infect the susceptible. And that is the rate of change in the number of susceptible depends on the number of infected, but with the opposite sign. But the fewer quantity susceptible, the slower their number changes. Therefore, you need to multiply it by the number of susceptible cells. And plus, coefficient is needed since the dependence is not direct and depends on the specifics of the epidemic process itself. And here, coefficient beta shows how quickly the disease is transmitted. So beta is transmission rate here. So let's see now how the number of infected delta I changes. With the number of infected, everything is a little more complicated. Since then, they not only increases, but also decrease. And as I said earlier, the states move one after another sequentially. That is, a susceptible turned into the infected state. And increase the number of infected. And that is the number of infected increases by exactly as much as number of susceptible ones changes. So it's readable with a sign plus here. And as we saw how the infected increase, we need to take into account the fact that they recover and go into the recovered state. So the more infected, the more people will recover. And that is, it depends on the number of infected people with another coefficient gamma, which is recovery rate. So we have the second equation for the changes in the quantity of infected people. So our model is almost ready. It remains to describe those who recover to delta R. And as I already said, the number of recovered will be equal to number of infected. So we are writing here infected with a recovery rate, but with a sign plus. And all these processes occur together. So equation is a system. And now we need to decide on the data, what will be the input of the model, where can I find the odds. This is a simple model which I just showed you. It's plots which were built by that formulas, which I just described to you. So usually at the beginning of the pandemic, we cannot influence the recovery rate. Here it's called removal rate, but it doesn't matter because we usually don't have special treatment for the specific infection, and the early diagnostics is not available at the beginning of the pandemics for the most countries. But we can influence the transmission rate by control measures such as wearing masks, lockdowns, and so on. So actually our task is to find out which factors impacts the transmission rate and how we can, which measures should we use to decrease the transmission rate. And actually you can see here the red plot is the quantity of infected, and the green one is the quantity of susceptible. And during the COVID-19 pandemic, a lot of people who were denying vaccination said that it doesn't matter, everybody will be ill somehow. But actually, it's not true, and we can see it from the model. If we will decrease the transmission rate slightly, we can see that at some point we can make that plots in such a way that they are not crossing each other, and that means that that quantity of susceptible population will never be ill, and we can do it after and so on. Also, why do we need to do that? You can see if we have a high transmission rate, we have a lot of infected people at a very short time. So we need to also, I'm confident that you have heard the term as flatten the curve, which means actually that we are trying to increase the time people will be infected to decrease like to make it possible to provide hospitals and beds in hospital for all of the people. Yeah, what I showed you was a simple SEIR model, but actually in real life we have more complicated dynamics and more complicated diseases. So it can be extended with different states, like exposed, removed state can be divided by recovered and dead, chronic disease for some of infectious diseases. Also, we can introduce different transmissions between that states, for example, from infected to recovered, from infected to dead, and so on. And it makes the model complicated, so we can have equations like that or even like that. And it's really complex, and it's very complicated to work with such models. So the main disadvantage of such deterministic models is that we cannot make quick changes to the model itself. So the infectious disease dynamics changes over time, and we have to change the model also. If we are talking about such complicated systems of equations, we need to rebuild that system every time when we have new strain, new measures, and so on. It takes time. It impacts the accuracy, and actually the accuracy of such systems is lower than from other models. Yeah, and also it's complicated and very cost. Like from computational view, it's also very complicated. So what we are working with, like one of the approaches, we are working with is agent-based simulation. Now it's like hype again. And when we listen, when we heard about agents, now usually it's, you have a question?
Yeah. From the previous model where you were showing, is there in the real data when the pandemic happened, do you have any how accurate the model is?
It depends on the infection. It depends on the region and on the model. And actually, I will talk about the accuracy a bit later. So we cannot look at the model and say that it's like high accuracy or low accuracy. It depends on the data and on the model. Yeah, agents. Now it's hype again, and when people are talking about agents now, they're talking about LLMs and like personal assistants and so on. But actually, that approach is well known for a long time. The idea behind that is that we are simulating humans as an agent, and we are simulating society as a multi-agent system with interaction between them and with simulation of epidemic process inside the society. Yeah.
Dimitri, I'm a bit confused. Are you talking about like a digital twin using it?
It like can be called like digital twin, but we are not in our models. We are not using any personal data. We are working on populational level. So we have different groups of people in society, and we can have agents with that characteristics. So they have like characteristics like age, gender, some behavioral patterns from one side, and on the another side they have like states, which I showed previously, like susceptible, infected, and so on. So we are not interested in the agent itself as a human. We are interested in the dynamics of the system on populational level. So such models, such agents have activities, that is, each agent is capable of organizing and implementing an action. Autonomy, it's independence from the environment. Purposefulness, the presence of their own sources of motivation. Like rational agents can have knowledge base which impacts their decision making. So they're trying to achieve a better expected result. For example, in our case, not to get killed or not to die. So we are simulating the system, as I also said, on individual level. We are tuning the characteristics of agents and rules of their interaction. And the behavior of the model itself, we can see the behavior of the model on the macro level as a result of interaction of the agents. And this is a big advantage because we can change the rules in the micro level, on the individual level, and it will impact the population immediately. So we can make experiments with the system and look actually which factors are influencing the dynamics the most. So it looks like that. We have like ill agent, and it spreads the infection. Some of agents became recovered, some of them are dead, and so on. So another approach is machine learning and deep learning approaches, and that approaches has very high accuracy. As you can see, we achieved with some basic models accuracy over 99% in different countries for COVID-19. for forecasting. But the big disadvantage of that is that we cannot look inside the model and we cannot interpret the results. So we cannot actually make experiments with that, but we can make forecasts with very high accuracy. So what we propose is a hybrid approach. So basically, we build agent-based models with characteristic of a certain society, certain territory, and so on. We build a machine learning or deep learning model for forecasting with high accuracy, and then calibrate the forecast obtained by agent-based model with a forecast obtained by deep learning or machine learning model. And as a result, we have high accuracy model, high accuracy interpretable model, which we can use for experimental studies. So let's look at some applied tasks which can be solved with such models. The first one was agent-based simulation of COVID-19 at the very beginning of the pandemic. We tried data from different regions of Ukraine and tried to estimate which factor influences the dynamics of infectious disease the most, and it was different for different cases, and actually it was used for development of policies in our country. And actually one of the co-authors of that paper is now the main epidemiologist in Ukraine. I developed that model here actually, and it's published in. It was published like 3 months ago with one paper, and I'm expecting the second volume of the paper like that week. So the idea was to complement that agent-based model with social patterns and misinformation. So we also had data on vaccination perception collected from survey from real people. We asked 1,000 people about their perception of vaccination and divided them into 4 groups, from fully supporters of vaccination to fully deniers. And then we had another model of misinformation, of health-related misinformation spreading. So it was the task was to look how misinformation impacts the perception of that agents about vaccination, how it impacts the infectious disease in general. To be short, it impacts a lot. So I've made several experiments for hypothetical disease X, which is like a term introduced by World Health Organization for future viruses and future pandemics. And all links to our works in presentation, and I can share the presentation later. So another important task is identifying factors which influences infectious disease. Here, the task was to find out which factors impacts the spreading of syphilis the most, and we found out that the most important factor is frequency of change of checks, and the second one is sexual partner consistency. The next task is finding out which percentage of population we should vaccinate to eliminate the vaccine-preventable diseases, such as measles, for example. If we will vaccinate enough people all over the world, we will eliminate measles globally. And our experiments show that we need to vaccinate 93% of children with first dose of vaccine against measles to fully eliminate measles. Let's do it like that. So the most popular task is forecasting of epidemic process of dynamics of infectious disease. And usually, if we are talking about forecasting in epidemiology, we are talking about short-term forecast, because we need some evidence to implement measures and to impact the epidemic with the dynamic process actually. Usually it's from 1 week to 1 month maximum. But in some cases, the task is to look long-term and to find out the long-term trends. For example, that work was about HIV, and we need to build models which can forecast for long-term to plan the antiretrovirus therapy, to plan the budgets like nationwide, so like province and province level. Another model we had, which is implemented actually in my region, in Ukraine, Kharkiv region, is epidemic threshold. So based on almost real-time data, it was like 1 week collected. It was incidence on influenza-like, influenza and acute respiratory virus infectious diseases. Morbidity, based on that, we built a forecast and we calculated the epidemic thresholds, and the epidemiologist, when he worked with that software, and when it see the crossing the forecast and epidemic thresholds, it means that he have to implement some measures immediately. So using that software, I believe 2 times our schools were under lockdown, and for last 12 years, Kharkiv region shows the lowest incidence by influenza all over the country. One more task is clustering. Usually when we're talking about measures, anti-epidemic measures, they're implemented nationwide or regional-wide, what we saw also in during COVID-19. So we looked at dynamics of COVID-19 in different regions of Ukraine and built clusters of the regions. So here we have 4 clusters. And it makes it possible to provide very fast measures, because you don't need to develop separate measures for separate regions. So it shortens the speed of implementation and the qualification. Since the Russian full-scale invasion of Ukraine, we also work on estimation of the impact of that war on infectious diseases, and we started from COVID-19 and analyzed some casualties and health facilities damages from open source. Then we built a methodology which was based on the model which I described previously, but the data for that is different. So we used data before 24th of February 2022 to train, and then build the forecast further and compare the accuracy of errors to find out actually whether the war impacts the infectious disease or not. And this shows that in Ukraine it impacted a lot, but none of the countries which received refugees from Ukraine were not impacted by, the spreading of COVID. At least was not impacted by refugees arrived in other countries. Now we are looking on exact factors and different diseases, like region-wide all over Ukraine. It's not published yet. But still we have some interesting results.
Dima, can you just go back to that previous one? So can you just, no, the color, the next one.
Yeah.
Can you just walk us through sort of verbally, I can't see what's under, what the horizontal deal is, but what's happening and what are the colors indicating? Tell me the story behind any one of those, please.
The green plot is actual morbidity, And that red is the date when the full-scale Russian invasion started. And we have a predicted trend of the model and like the verification trend. So we can see that in some cases we expected less incidents after the war started. Like, and actually we had a lot more. But in some cases, which I'm not here.
Probably the last one, right, is more,
I think that one is better, that we expected like a higher
Yeah.
incidence than we have actually. But we also have to find out what impact that, whether it's under registration,
right,
and we don't have like enough registered cases, or whether actually we have even more cases because of evacuations through overcrowded trains, like overcrowded shelters,
Right.
and so on. So yeah, that's what we are working on.
so that would feed back into tweaking the model to include
Yeah.
some other aspects as the war
Yes, exactly.
continues and so on, is that the kind of thing? Okay.
Okay,
Thank you.
I will skip that and we'll come back to that a bit later. So another work I'm doing here is looking at data. So the first problem was actually that different researchers all over the world are working with different types of data. Some are working with cumulative data, some with daily data, some with acute, some with chronic. And that means that a lot of people are working actually on the same task, but we cannot compare our results because we don't have any baselines. So in my Balsillie paper, I'm writing about the standardization of the data for different researchers and how actually which data should be used for each tasks. But during that work, you know, when you're starting working on one aspect, you're finding out a lot of different other tasks. The first one was working with like outliers in epidemic data and looking at smoothing techniques that can increase the accuracy of our models. And it's important like for all over the world. For example, when we had COVID-19, like nurse can register morbidity every day, but during the weekends, she go to like for other work and coming back on Monday, she will input all the data which was collected during the weekend as a Monday statistics. So we have outlier on Monday and on Saturday and Sunday, and we have to find out what actually was the real infectious disease morbidity to build the models. So we looked also on different models in different countries and tried to find out which smoothing techniques are the best. And another work which is not published yet also is about data imputation. So it's actually about the under registration when we have missed data. So we're also looking in different countries and different epidemic process and different techniques to find out which methods can be used to fill that missed data. So we took actually data sets from different countries and took some data out from there and trying to generate synthetic data to fill in that gaps. Yeah, and what I'm working on also is a multi-level comprehensive approach on like public health informatics and pandemic preparedness, which I think continues the last week presentation from Bo, where we had micro, meso, and macro level, but from another perspective. So on macro level, it's about individual diagnostics and using computer science for diagnostics, like Internet of Things and wearable devices to monitor the health. Meso level is resource optimization, which I didn't describe today, but it's another huge topic. For example, how to optimize human resources in hospitals, how to relocate the hospitals itself or vaccination points to obtain the best result. And macro level is population dynamics. That's what I'm talking about today, actually. And based on that macro level models, we can provide decision support systems for policymakers. Yeah, so to conclude, simulation is very effective tool to prevent pandemics, to prevent epidemics, and it can be a tool for policymakers to make evidence-based decisions regarding any measures. So thank you for your attention.
Dimitro, that was so interesting, and all those graphs, I love the interactive graph in particular, and I was thinking, wow, you could do a lot of if then, you know, there's some scenarios in there, aren't there?
Yeah.
I'm sure the policy community is very interested in these things, but congratulations with all your
Thank you.
peer-reviewed publications from this project phase of your work and sharing all those wonderful details with us.
Yeah, thank you for that opportunity.